lunch, or in fact, even we didn't have our lunch. We'll move to the Community Social Ophthalmology Part 2 and the free paper section. The duration of each free talk is 6 minutes, so please stick to that. The keynote speaker duration is 10 minutes. Regarding the presenting author, please introduce yourself with your AIOC number. If you are not a ratified member, you can't be part of any award. The award shall be considered only for the research conducted in India. If there are absentees, please indicate yes, absent. So with me, I have, I'm Dr. Vibhuti Sinha from Patna. With me, I have Dr. Ajit Kumar Podar from Mastichak Eye Hospital. That's a large community-based hospital from Mastichak in Bihar. As co-chairman, Dr. Sajjad Ahmad Khasik, Vishnu Vahan Prashan, and Dr. Deepak Mishra. So two people are here to join us. We'll move starting from free papers number 341, that is slit lamp photography of corneal ulcers to predict healing trajectories. Dr. Prashna NV. Timer. 6 minutes for each free paper. Yeah.
Good afternoon. I'm here to present slit lamp photography of corneal ulcers to predict healing trajectories. I'm Dr. Preeti with my ratified membership number G2019, sir. Corneal ulcers are a leading cause of blindness in the developing countries, especially working adults. Ulcers vary depending on microbial morphology, patient and environmental factors. Despite the wide variation, broad-spectrum antibiotics are given to a lot of patients because ulcers require rapid intervention. We can change to targeted medication only days later and only if the culture results are conclusive. Currently, monitoring of ulcers is done qualitatively, which is subject to variability because they measure dimensions of the ulcer. Computer-aided quantified automated measures have changed the way patients are managed in many diseases like keratoconus, macular degeneration, glaucoma, etc. Yet a quantified algorithm doesn't exist for corneal ulcers, which if present would provide an earlier endpoint clinical measure for the impact of intervention. In fact, corneal ulcers provide an ideal disease for development of tools for their morphological analysis because of their rapid disease course and their short interval. Patients' potential outcomes could be distinguished if researchers address critical barriers in how we collect, measure and analyze these data. Our project team consisted of cornea specialists from Aravind Eye Hospital, Kellogg Eye Center, Michigan, and applied ophthalmic engineers from the Duke University. In order to achieve the long-term goal of predicting ulcer outcomes and to personalize treatments, our current objective of this study was to collect and create digital quantified measures of the ulcer characteristics. A sample of 50 cases recruited from Aravind Eye Hospital at the cornea clinic was studied over a period of 1 year. Patients were stratified based on age and gender, and the standard of care was the same in all of them. Any patient more than 18 years with a clinically significant untreated corneal ulcer of more than 1 mm in the greatest linear dimension as measured by the ophthalmologist was included in this study. They were excluded if they had no PL, prior corneal surgery, impending perforation or perforation, and if they were pregnant. All the patients underwent slit lamp examination, corneal scrapings and serial slit lamp photographs in 10x and 16x magnification in white light and cobalt blue light in a Canon 7D camera mounted on a Hague Street slit lamp. Inner white-to-white measurement was done by anterior segment OCT. Health-related quality of life was evaluated by Indian Visual Function Questionnaire that consisted of 33 questions validated in English and Tamil, along with an 8-question interval visit questionnaire. Quantitative corneal monitoring semi-automated software package, which we have developed from the previous studies, were used for image-based analysis. Demographic information and patient risk factors were gathered. The height and width of epithelial defects, stromal infiltrate, presence of hypopyon, degree of corneal thinning, depth of infiltrate and consolidation at the edges was noted. The average age of our cohort was 47 years with a predominance in males. Fungi contributed to the majority, followed by culture-negative cases and bacterial cases. The mean inner white to white was 9.5 mm. At the initial presentation, the dimensions of the epithelial defect as measured by the ophthalmologist was on average lesser than the corresponding image-based measurements. Non-central ulcers contributed to 56%. Hypopyon was seen only in a third. Depth of the ulcer was 37% at presentation. Mean, standard deviation, range and median for both the examiner and image-based measurements were calculated, and scatter plots were used to assess the agreement in between them. Absolute differences between them were noted and tested for deviations by Wilcoxon signed rank tests. The percentage of absolute measurements as well as the relative difference was very negligible between the ophthalmologist and image-based measurements. A Kruskal-Wallis Hedge test showed that the height of epithelial defect measured by the ophthalmologist was statistically significant between the fungi, gram-positive cocci, gram-negative bacilli and culture-negative cases, but no other measurements differed between the organism type. While the general, visual and psychosocial function were not different by the microbe type or the location of the ulcer, an overall impact was seen on the general function. This was how the fungal ulcer healed over a period of time. This is culture-negative case, and this is a bacterial corneal ulcer. A less sample size and imprecise measurement of ulcer dimensions during follow-up was a limitation for this study. Computerized studies like these need good, consistent quality photographs, which otherwise lead to variability. In future, we aim to create visualized ulcer trajectories with healing over time, and statistical analysis will be done by linking this data to the host pathogen. For this, we need a large sample size and a long-term follow-up, and we aim to create user-friendly algorithms that predict heterogeneity of the patients in the long run and personalize corneal ulcer treatments at disease onset. So our central hypothesis is that by combining accurate corneal morphology measurements with host and pathogen characteristics, we'll effectively distinguish patient risk levels for visual disability and corneal transplantation at the disease onset. These are my references. Thank you.
Thank you. Was the depth also taken into consideration?
Sir, what is?
Depth.
No, sir. Yes, sir. We have used
photograph which you are taking.
They were all standardized, sir. According to American Telemedicine Association, sir. The imaging standardized.
So what is your take-home message?
Sir, in the future, we aim to, suppose if a corneal ulcer presents to the OPD, we aim to provide a software where we can include all the patient characteristics, and so that we can tell the patient how it will heal over a period of time and if we might need a corneal transplantation. So this is like telemedicine screening, just like how we do for diabetic retinopathy.
Any question?
How do you think it will be helpful to the larger section of society where everywhere the straight line photography is not?
That's why it is a long-term study, sir. But definitely imaging should be there in such cases, sir. Rather than external photographs and smart photography, where they have good specificity but the sensitivity is less.
Thank you.
Thank you, sir.
The next presenting author is Dr. Radhika Krishnan. The paper is about ignorance about diabetes is not always bliss.
Good afternoon. I am Dr. Radhika Krishnan. My AIS number is 15839, and I am going to talk about the existing ignorance about diabetes and diabetic retinopathy. We all know India is home to about 73 million people living with diabetes, of whom 58.4% are unaware that they have diabetes. In addition to this, an additional 10.3% of our population aged 20 plus is known to be in the pre-diabetic state, 60 million with pre-diabetes. That is a huge burden. An AIS study, the READS paper, estimates the prevalence of diabetic retinopathy in known diabetics to be about 21.7% across the nation. And this is bound to increase with the number of diabetics being detected. Our own project, the Aditya Jyot Diabetic Retinopathy Urban Mumbai Slum Study, DRUMS, is an ongoing population-based cross-sectional study conducted in the slums of Mumbai. Our model is an epidemiological survey where there is a door-to-door approach. The health workers are doing an awareness and a screening for diabetes, followed by a diabetic retinopathy screening, which is done in the van, and referrals happen for further treatment. As a part of this study, we included a questionnaire on the knowledge levels of diabetic retinopathy among diabetic patients and the major hurdles they have in seeking eye care. 1,373 eligible subjects were enrolled in the study, and they were asked two questions. How did you come to know that diabetes can affect the eye? Second, being a diabetic, why did you not go for an eye examination? The results, we found that the causes for the diabetic patients, even after being detected diabetic, not going for an eye exam, lack of awareness, about 49.2%, financial constraints, 22.5%, busy schedule or other reasons, 15.5%, and a 12.8% of people thought that it was a sheer waste of time. So the major cause that we found of not seeking eye care was found to be the lack of awareness, which was noticed in more than half of the study population. Out of all the methods of awareness that were available to them, we found that the majority of them, about 73.49%, found out about the complications of diabetes either through the state-run ASHA health workers or our own community health workers. In addition, the other sources which we looked at were physicians, opticians, ophthalmologists, optometrists. All of them put together contributed at 26.51%, and this is in a city of Mumbai. India has a lack of access to early screening for a variety of chronic eye diseases, resulting in an increase in expense on tertiary eye care, increasing prevalence of preventable blindness, and inefficient utilization of our healthcare resource. There is also a huge shortage of trained ophthalmologists, especially in the rural areas. I would like to focus attention on the National Health Mission, where the ASHA or the accredited social health activists have been used to strengthen the decentralized village and district level health planning and management. One of the core strategies of the NHM was to promote access to improved health care at the household level through the ASHA. This has worked by providing every village in India with trained female community health activist volunteer. I stress on the female because they form an appeal to the integral households, to the women in the households, and they are able to bring about changes in determinants of health like nutrition, sanitation, and hygiene. The role of ASHA, they have over the years, it has been seen, they have mobilized the community towards local health planning that increased utilization of primary health care and thus place the health of the people in their own hands. They play a potential role in providing primary health care at the village level. So we would like to suggest that since the most effective mode of patient awareness that we found was either through the state-run ASHA or through our own community health workers, we propose that a similar model for better reach of eye care programs should be adopted in the community as a whole. To conclude, we found that the major cause of diabetic patients in the slum population not seeking eye care was lack of awareness, with financial constraint being only the second highest cause. The most effective mode of patient education was found to be through our community health workers, and therefore we suggest that we need to focus our attention to train and incorporate diabetes screening in the NHM through the ASHA workers to reduce the cause of vision loss due to diabetes. These are my references. Thank you.
And thank you, Radhika Krishnan. It's very well presented. I have just a simple question on a lighter note. Can the ignorance about diabetes ever be a bliss?
No, it can never be a bliss.
So, so thank you.
Thank you.
Just an announcement. I'm supposed to announce the best paper of previous session. All 5 of us finalized it. The best paper of previous session is free paper 1805, aponeurotic variant of congenital ptosis managed by levator reinsertion by Dr. Ankit Singh Tomar. That I'm
Yeah, no question.
Sorry, what did you mean by the lack of awareness? I mean, awareness, what was the question basically that was asked in that?
Were they
Question?
aware that diabetes can lead to vision problems? That is, it is necessary for a diabetic to have a retina evaluation or an eye checkup.
About the importance of a retina evaluation.
Yes.
So there were a single question.
No, there were two questions.
Questions
Yeah.
actually. Thank you.
Thank you.
The next paper is free paper 1065, that is screening for diabetic retinopathy in rural population, assessment of need and compliance to treatment. The presenting author is Dr. Girdhari Gupta is here. You are not a ratified member, as I presume, since we have been given that membership number up to 21253 are ratified. So your paper doesn't qualify. 21253. No, sorry. 21253. No, actually you are not ratified yet, so your paper doesn't qualify for the best paper award, but you can present.
Yes.
Please go ahead.
AIOC था ना, डेस्कटॉप पे जाओ।
नहीं डेस्कटॉप में मैंने इसमें ट्रांसफर कर दिया
नहीं है ना इसमें,
नहीं
डेस्कटॉप पे। डेस्कटॉप पे, उसमें। दिस वन फुल कर दो ना। ठीक। Good afternoon all. Myself Dr. Girdhari Gupta. My membership number is 21378. My topic is screening of diabetic retinopathy in rural population, assessment of need and compliance to treatment. The introduction: what is the current scenario of diabetic retinopathy? Zhang et al. In 2012, globally the number of people with DR will grow from 126.6 million in 2010 to 191 million by 2030. And it is estimated that number with vision-threatening diabetic retinopathy will increase from 37.3 million to 56.3 million if prompt action is not taken. A study on epidemiology of diabetic retinopathy published in 2015 by Ryan Lee et al. Showed that out of the estimated 285 million people with diabetes mellitus globally, approximately one-third have diabetic retinopathy, out of which a further one-third of DR is vision-threatening DR, which also include diabetic macular edema. What is the visual status in diabetic retinopathy patients? A study by Narendra et al. Showed that prevalence of near normal vision is about 70.2%, visual improvement in 11.9%, severe visual improvement in 1.5% of non-diabetic patients. A study by Oliveira showed that in patients diagnosed with clinical, often asymptomatic type 2 diabetes, 6.3% were visually impaired. Among those patients with reduced sight, 76% had cataract and 50% had retinopathy. A study by Shrestha et al. Showed that diabetes accounts for legal blindness in 83% of visual improvement among persons with youth onset diabetes and 33% among persons with older age onset diabetes. Around two-thirds of diabetics have an increased possibility of visual improvement after 35 years of suffering the condition and are 25 times more likely to go blind compared with other conditions. Visual improvement increased with increase in grade and severity of diabetic retinopathy. The diabetic retinopathy is the leading cause of blindness among the working age adult population aged 20 to 74 years. Diabetic retinopathy can be treated with modalities that have been proven to decrease the risk of severe vision loss by more than 90% if early detection is made. Diabetes alone can increase the risk of blindness 25 times. Then compliance of screening and treatment. Closet Hall et al. Assessed the need of people living with diabetes and diabetic retinopathy in 5 rural district hospitals in Kilimanjaro region and observed that low level of self-efficacy, high level of anxiety and depression have a negative impact on compliance for screening of diabetic retinopathy and concluded that need of comprehensive accessible diabetic education to prevent diabetic retinopathy. Salah Memon et al. In observational case study assessed the acceptance of retinal screening, laser treatment uptake and subsequent follow-up in diabetics in Urban Diabetes Care Center, Karachi. In this study, 100% compliance was observed for retinal screening, 70% for laser treatment uptake and 21.25% of the patients who await laser treatment and follow. So, my methodology, It is a rural diabetic population-based screening was done to assess the need and compliance to treatment. The type of study is cross-sectional observational. Place of study was government health facilities including CHCs and IOPD and tertiary care hospital. Duration of study was 1 year. Study subjects non-diabetic populations. Inclusion criteria is all non-diabetic patients at government health center CSCs and attending IOPD. The exclusion criteria was patient not giving consent, patient who are uncooperative, hazy media, and patient with posterior segment pathology other than diabetic retinopathy. All diabetic retinopathies who were referred in our hospital during this period were considered for the study. After taking informed consent for the patient, data was collected. Non-duration of diabetes, type of DM, nature of treatment, data was collected. Restricted visual acuity was tested using ETDRS. Examination of posterior segment was done. Slit lamp was done, slit 90D, and grading of diabetic retinopathy was done. And the grading was determined according to ETDRS modified earlier house classification. Fundus photograph was taken for each patient irrespective of grade of diabetic retinopathy. Fundus fluorescence angiography was performed by 3-netra fluora camera wherever required. Baseline OCT was done on Zeiss Primus OCT. V-scan USG was done in hazy media as in vitreous hemorrhage retinal detachment. And visual acuity, the ETDRS notations was converted to Snellen's notations. According to WHO criteria, blindness status was divided into 6 categories. Then the need for treatment of diabetic retinopathy. Based on the severity of diabetic retinopathy, patients were classified into non-sight threatening and sight threatening. Sight threatening was included clinically significant macular edema and or severe non-proliferative retinopathy or clinically significant macular edema and or proliferative retinopathy according to definition by the ETDRS and treated with either laser or intravitreal anti-VEGF. Patients with mild and moderate non-proliferative diabetic retinopathy were categorized into non-sight threatening diabetic. Severe and PDR was treated with PRP. This is the visual acuity testing by TDRS. DDO was done, then DO was done, 90D, FFA. Then this is the normal fundus, then the mild MPDR with CSME. Then this is the moderate MPDR, then moderate NPDR with CSME, severe NPDR with CSME, and PDR with CSME. This is a photo with PDR with HRC. You can see the retinal hemorrhage also and neovascularization, and advanced PDR with tractional retinal detachment. This is a photo, OCT was done, diabetic macular edema is there, and the USG scan showing RD and vitreous hemorrhage. Then the laser treatment for diabetic was done, post-laser fundus photograph was taken, and this is the intravitreal anti-VEGF injection was given. So, observation and result. During the study period, 7,884 non-diabetic patients registered. Among these, 7.7% patients were diagnosed for diabetic retinopathy. The compliance, in spite of free treatment with provision of transport, out of 608 referred patients, only 252 patients attended with compliance of 41.4%. The compliance was observed more in male population as compared to female population.
Please summarize.
Compliance was more observed in urban population as compared to rural. Then the visual acuity in eyes who needed treatment, around half of the eyes were having near normal vision. And out of 207 eyes requiring treatment, 70.4 needed macular grade, 30.4 PRP, 37.7 intravitreal anti-VEGF, and 14.5 needed both PRP and intravitreal. Among those who treated, out of 2007 patients requiring treatment, 185 were treated, and among them 25.95 patients lost their follow. So I will conclude almost half of the patients with DR needed for treatment in view of preserving vision, but half of them had a good vision, which is the main cause of reduced compliance to treatment. So diabetic retinopathy is also an iceberg disease like a DM, the disease without the symptom. Reduced compliance for treatment is due to lack of awareness, lack of education, lack of accessibility to eye care, and socio-economic constraints. These are my references. Thank you.
Thank you. The next free paper is free paper 1671, that is glaucoma blindness. Are we contributing? And the chief and presenting author is Dr. Nidhi Pandey.
Explain, madam. Explain.
The timer needs to be reset.
Timer starts now.
Like, oh yeah.
A very good afternoon to all of you. My membership number is P07183. I'll be presenting my study titled Glaucoma Blindness, Are We Contributing? Glaucoma, as we all know, is the most common cause of irreversible blindness, and its prevalence is increasing with the increasing life expectancy. Though it has been clearly shown that early recognition and treatment is associated with overall decrease in cost of management and improved quality of life, but it is still a challenge. Though there are some patient-related factors which are responsible for its late diagnosis, like it is mostly asymptomatic in the early stages and there is lack of awareness about it, previously done studies have also indicated towards inadequate identification of glaucoma by experts, and these studies were done about a decade back. So to study this aspect of glaucoma blindness, we undertook this study to evaluate whether patients presenting with advanced glaucoma had sought prior ophthalmic consultation. It was designed as a retrospective observational study in the Department of Ophthalmology, Medical College, Raipur, and we included patients presenting with advanced primary glaucoma. We took the detailed history from all patients, and we specifically asked them about prior ophthalmic consultation, whether it be from ophthalmic assistants, technicians, or ophthalmologists, whether in hospitals or eye camps. And we also asked them whether they had prior information regarding their diagnosis and whether they were having regular follow-up visits. And routine examination was done for all the patients. We recruited 36 consecutive patients presenting with advanced glaucoma, and their age ranged from 42 to 72 years. There were equal number of males and females, and the primary open-angle glaucoma was the predominant type of glaucoma in our study. Most of the patients were either illiterate or had received just a primary or secondary level of education. Most belonged to the lower socioeconomic status, and most were residents of rural areas. 9 patients had undergone cataract surgery in one or both eyes within the past 5 years. Out of these, 3 had undergone the surgery in the past 2 years, and family history was negative in all our patients. 15 patients had consulted an eye care practitioner in the previous 2 years and had not been diagnosed as glaucoma. 5 had been prescribed glasses, 2 being diabetic were advised for retina consultation. 5 had consulted in eye camps and had been prescribed glasses or advised cataract surgery. 3 had undergone cataract surgery in the past 2 years. Another 15 patients had been previously diagnosed as glaucoma and were prescribed medications, but they showed inadequate compliance and did not have regular follow-ups, and all of these belong to the low socioeconomic group. 6 patients had not consulted anywhere previously. So a comprehensive eye examination is essential for early detection and management of glaucoma. It is very essential to do an opportunistic screening, at least for all those patients above 40 years for glaucoma, for whatever problem they present to us with. And for those at risk factors, screening at all ages must be mandatory. Eye camps should have facility of tonometry and fundus examination. Otherwise, they give a false sense of security to the patients that everything is all right in their eyes because they have already consulted somewhere. Phone-based fundus camera for posterior pole photography with subsequent opinion from experts might be a good option. Screening for glaucoma of all patients brought from outreach camps for cataract surgery should be mandatory. An equal number of our patients had been diagnosed as glaucoma but had discontinued regular use of medication. This raises the issues of affordability and counseling, which are important aspects in adherence to medication. A previously done study had shown that in the low-income group, as high as 137 of monthly income was the total expenditure of glaucoma management. So a subsidy on glaucoma medications or insurance coverage can be advocated by us. or based on the socio-economic status of the patients, an early filtration surgery might be considered. There are certain limitations of our study, like the participants were enrolled from the same institute, which caters mostly to the low socioeconomic group. A larger sample size might have been more representative. To conclude, 83% of those presenting with advanced glaucoma had contacted eye care practitioners previously. Diagnosis was missed in half. Rest had inadequate compliance. The study outcome re-emphasizes that to help reduce the burden of blindness due to glaucoma, a comprehensive eye examination for every patient presenting to the eye care facility should be done. Glaucoma must be ruled out as part of every regular eye examination. Patient education to be an integral part of management. Compliance and affordability to be important considerations in managing glaucoma patients. Thank you.
Do you consider pupillary dilatation as a part of comprehensive eye examination and gonioscopy as a part of a comprehensive eye examination?
No,
Or-
no.
No, not in this case.
No, but they were all patients with glaucoma, advanced glaucoma, so we did all these tests in these patients. Otherwise, disc examination should be mandatory in every patient. It should be a part of comprehensive eye examination. It can be done very well in the undilated pupils also, and it gives very good indication. That is my belief.
And Albany had an issue with the compliance. I mean, the amount of money to be paid for the drops, and they dropped out, did not put the drops.
Yes, almost 43% of the patients had issues with compliance, because some of them were so poor that they didn't have even money to for their food. So it is like unlikely that they will have the money for the drops. So maybe we as a society can advocate affordability. Some glaucoma medications can be, prices can be made more affordable.
Any question, Dr. Deepak?
Nothing, sir. It's okay.
Thank you.
So the next paper is free paper 1188, a blind school survey, an attempt to identify needless blindness. The chief and presenting author is Dr. Sabyasachi Chakravarti, S16242.
Good afternoon, everyone. I'm Dr. Sabyasachi Chakrabarti. My membership number is S16242, and my free paper is titled "A Blind School Survey: An Attempt to Identify Needless Blindness."
Timer, please.
None of the authors have any financial interest in the contents of this paper. So, introduction. Childhood blindness, although uncommon, is a huge social burden because of the large number of blind years it generates. Population-based data on childhood blindness is difficult to obtain because these entail evaluation of very large samples. This study is a blind school survey which hopes to provide a glimpse of the characteristics of childhood blindness in the South Indian population. Material and methods. The study site was a blind school located in Palayam Kottai, Tirunelveli, Tamil Nadu. The study population included all pupils enrolled either as a day scholar or as a hostelite in the school. The design was descriptive and cross-sectional. The aim of the study was evaluation of the causes of blindness and low vision in a blind school in a Tier 3 city to assist in the planning of low vision services. The objectives were to determine the different etiologies of visual impairment in children studying in a blind school, to determine the visual potential of candidates in a blind school, and to determine the frequency of avoidable causes of blindness. Data collection methods. Demographic data of the children and a brief family history were obtained from the school records and the staff. Distance visual acuity was assessed by OroChat, OroLab Madurai, India. Refraction was done by loose lens retinoscopy. If the child failed the distance vision test but there appeared to be some useful vision left, tests for functional vision, namely independent mobility, social contact and near vision were performed. Trials for low vision aids were performed for all patients with low vision with at least some degrees of functional vision. The LVAs tested were high plus lenses, hand magnifiers, stand magnifiers, and spectacle mounted magnifiers. So this is an LVA trial going on in the survey using a stand magnifier. The anterior segment evaluation was carried out with a torchlight. Fundus evaluation, if indicated, was done using an indirect ophthalmoscope after full mydriasis. So these were the techniques of anterior and posterior segment evaluation in the study. Statistical analysis. Continuous variables were summarized as mean and standard deviation. Categorical variables were summarized as frequency and percentage. And the data thus collected was analyzed using OpenOffice Calc for Windows version 4.1.4. So some descriptive statistics. The total population tested was 149 with a mean age of 12.13 plus minus 3.16 years. Males outnumbered females. Males were 91 and females were 58. This is the first pie diagram which shows the levels of visual impairment in the 149 surveyed children. Almost 52 children had a visual acuity of less than 1 by 60. Low vision was present in 57 and 76 were blind. This pie diagram shows the major anatomical site of involvement for visual impairment. Whole globe involvement was found in 42 cases, which included microphthalmos, anophthalmos, cryptophthalmos, and phthisis bulbi. This chart summarizes the etiologies of visual impairment. Most of the causes were undetermined. Hereditary factors were responsible for 28 cases. This pie diagram shows the different preventable causes of vision loss. There were 13 preventable causes and the most common cause was trauma. This pie diagram shows the different treatable causes of vision loss. A total of 35 treatable causes were noted and the most common cause was pseudophakia with amblyopia. Coming to discussion. A preponderance of males over females may simply reflect a social bias towards educating males rather than a chromosomal difference in the prevalence of blindness. 16 children had no visual impairment. Similar findings have been reported in other contemporary studies as well. Developmental anomalies accounted for a majority of the vision loss, 29.32%. One may speculate that a majority of these anomalies are due to a genetic disorder which is common in these parts because of the practice of consanguineous marriages in this area. Developmental anomalies are also the commonest reported causes of blindness in other blind school surveys. Overall, the proportion of corneal blindness was very low, 5.3%. This may be because of a good coverage by immunization. In this study, 36.09% children were found to have an avoidable vision loss. Pseudophakia with amblyopia was the most common cause. Out of the 7 children with unoperated cataracts, only 1 was operable and was sent to the base hospital for further management. A similar proportion of lens-related anomalies has been reported from Cambodia and Malaysia. Although the proportion of congenital glaucomas was much higher than that reported in the general population, 5.3% versus 1 in 10,000, it is difficult to state whether this is a definite trend or a manifestation of Bergsonian bias. Refractive errors and amblyopias as causes of avoidable blindness simply indicate a lack of awareness among the general population regarding routine ophthalmological evaluation in children. Cicatricial ROP was seen in only one case, 0.8%. This may simply reflect high infant mortality rates, where ROP is rarely seen due to scarcity of neonatal care facilities. So my conclusion, the pattern of childhood blindness seen in this survey is very similar to that shown in previous ones despite the unique socioeconomic characteristics of the studied region. The prevalence of preventable blindness can be reduced by strengthening the primary level services, but the prevalence of treatable blindness can only be reduced by improving pediatric ophthalmology services in the area with a comprehensive approach which should include early referral and rehabilitation facilities. Thank you.
Thank you. Any question?
Did the children with good visual acuity, did they undergo thorough retinal examination also? I mean, to rule out any RP or anything like that?
All of them underwent thorough retinal examination. These children with very poor, good visual acuity had been enrolled into these blind schools because they had some other impairment and there were no other special schools. So one child had mental retardation, few of them were deaf, so they could not be enrolled into normal schools and they had simply been enrolled in that special school.
So it was like a special school, but...
Yes.
One suggestion, if you can go for the community screening, instead of torch, at least you can use the direct ophthalmoscope. That gives some better examination techniques of the anterior segment and at least the central part of the retina too.
Sir, we did indirect ophthalmoscopy with mydriasis in all cases where we could see.
That is for the selected cases, but initially anterior segment you screened only by the
with
torch.
Torchlight, yes, sir. Yes, sir.
Okay, thank you.
Thank you, sir.
Now we have the keynote address of this session to be addressed by Ms. Renu Wadhwa. Her presentation is on customization in community ophthalmology, a little thoughtfulness creating a major impact on patient care. Ma'am, your time is 10 minutes.
Good afternoon. I represent the KKI Institute of the Sadhu Vaswani Mission, which is a humanitarian organization concentrating in the areas of health, education, seva, and spiritual activities. The topic that I'd like to run through today is customization in high-volume community ophthalmology. A little thoughtfulness can bring about a major impact on patient care. Do you want me to continue? Yeah. The topic I'd run through today is customization in a high-volume community ophthalmology program. A little thoughtfulness can bring about a major impact on patient care. There are no financial disclosures to this presentation. A common perspective that prevails is free means a neglect in healthcare services. Charitable means a substandard quality. Community ophthalmology means treatment of masses with a herd mentality. Even though we want to give the best care to our patients, we are often caught up with what is exactly the via media between our ideals and a pragmatic way out, between issues of morality and money. Is there really a trade-off between cost and quality? Yes, there is. By making a few minor changes in our workflows and patient flows, we could bring about a personalized, a customized approach to even a high-volume community ophthalmology program. One of the major areas to focus on is the skilled hands of surgery. Any institute with junior and trainee surgeons needs to have very committed faculty to ensure that learning is not at the expense of surgical outcomes. A practical surgical review at the time of appointment also ensures that practical skills match off the polished CVs. Having regular audits by way of live random sampling of several patients operated in the past few months brought back to the hospital and being assessed by an independent authority, or any of the in-house senior surgeons observing vision on the day one of post-op across all surgeons, or even the conventional method of analyzing pre-operative vision and post-operative vision. What's really important is to set aside allocated days and timings for this audit so that to ensure that it's not a neglected activity. Charting out growth of technical skills at a snapshot gives what each surgeon can do so that we discourage any kind of technical experimentation. Also, it helps to have a definitive, monitored technical growth. Analyzing resurgeries and delayed discharge patients are an important indicator of surgical outcomes. The mandatory follow-up mark placed on every file for all intra-op complications and complicated conditions ensures that that patient is brought back at least 2 times for follow-up, and also lists out as to what happened to minimize that occurrence in the future. If a person knows what he's to do, is made aware of, and understands, there is more reason that he will follow it. We need to break the illiteracy barrier by a lot of counseling. Live counseling could be done actually using a sound system and live mic at the campsite, orienting them about the entire process, understanding what medical illness they have, what kind of current medication they are on. At the time of admission, explaining to them not to spit around, not to wander, not to panic if their surgery is not done, where is the emergency help desk, and most importantly, the post-operative instructions, giving them the do's and don'ts, and simple things that we take for granted, like for example, opening a bottle of eye drops, which we know we just need to twist the cap, but they probably just pierce it with an unsterile object. Reiteration is the key to counseling, to the effectiveness of counseling, because more times you repeat the instruction, hopefully more of it will sink in and there's greater compliance. Who is talking? A paramedic, a doctor, an optometrist. His word holds more weight. Audiovisuals have a great impact. We've tried it out, and playing them continuously in the post-operative wards has a greater compliance to follow-up and follow-up care. Printed graphics and illustrations serve as a take-home reminder. This is one of our live counseling, watching the audiovisuals and printed illustrations. Inculcating a follow-up culture is really important. Every service desk which is dispensing some service to the patient needs to reiterate the follow-up, and this is facilitated through pre-printed designs, follow-up schedules which are pasted at every desk. Reiteration also means even the driver who drops back the patients tells them, okay, I'll see you on so-and-so date back at the hospital. Vision centers, of course, offer care at the doorstep, so there is greater compliance. Inculcating the fear psychology, telling them that their treatment is not complete until and unless they come back for follow-up, also improves follow-up percentages. Some of the extras, while queuing in for the OR, it's very common that they exchange files. So at every desk, you need to reiterate the name confirmation, encourage an open culture so that the patient gets the best care by the specialist, comprehensive panel of pre-operative investigations, post for other medical specialties. We may not be able to treat the patient for a cardiac or an asthmatic condition, but we could at least refer them and they get counseled on how to take care of their problem locally. Correct eye marking. Post-operative care, giving them the medication for 2 weeks and a pair of dark glasses. Case file audits. Discouraging handing out standard part spectacles, because we all know there is a cross power after surgery. Analyzing rejects at the campsite as well as the hospital. Special indicators for hard of hearing patients, diabetic and one-eyed. We tape the ears of a hard of hearing patients with white tape, or diabetic patients have a colored band so that they are served that kind of diet. Straight from the horse's mouth, getting feedback from the patients is an important indicator of how efficient your services are. Asking a delayed discharge, do not discharge patient, how many times the drops were administered, and if his answer is 2 instead of a 6 or an 8, it actually indicates the efficiency of your post-op nurse. A single case of end-off is, of course, very disheartening and diluting to our objectives, but backtracking actually what went wrong opens up a Pandora's box of improvements. Coming down to the basics, it's very important to have well in advance prepared training calendar with well marked out dates and timings allocated for training, so that it doesn't happen only when there are low volumes, and it's done for all categories of staff, right from security guards to doctors. Manuals and SOPs, it helps in standardization of systems, as well as it avoids a step down in quality when one person leaves and another joins. Aligning one to the vision. If the vision is actually patient care, we need to mold the mindsets accordingly. Patient care is not an extra activity. It is not an additional effort. It needs to be ingrained as part of the regular activity to form a spontaneous culture of caregiving. And this happens much more easily when you try to align the consciousness of a person to the higher, which will automatically guide them towards what is right and wrong, rather than an external supervising entity always telling them or correcting them what is wrong. Having regular prayer meetings directs them to the inner conscious. Finally, it just comes down to the moral science lessons of apathy versus empathy. I'd just like to illustrate this point with 2 examples. I was taking around the ward, and I found this old Aji sitting here with a branded jersey, and it looked quite odd. So I asked the nurse, and she said, "Ma'am, jab tak sweater store se aaya, maine apna khud ka de diya." Another example that happened quite recently was one of our project managers had a cardiac arrest. He cried like a baby because he couldn't afford the bypass surgery. Another field manager just walked up to my room and said, "Ma'am, mera 11 years ka gratuity hai, just transfer it for his bypass surgery." So that's the kind of culture that we need to keep trying to inculcate. That happens as part of the routine rather than extra effort. I'd like to thank you for your patient hearing and leave you with this thought. As stakeholders in the healthcare industry, I believe this is of paramount importance. Thank you so much.
Thank you. In fact, we all need this kind of, we need to follow those behaviors patterns in our day-to-day practice. The next paper is the best state paper from all Gujarat Ophthalmological Society. that is predictability of devices in differentiating keratoconus and some subclinical keratoconus size from the normal eye. Dr. Pooja Kamar is the presenting author.
Yeah. Thanks a lot. My membership number is K17849, and at the outset, none of the authors have any financial disclosures to make pertaining to this study. This was a LASIK patient who came for a refractive surgery in 2005, but we found that all the indices were normal, but we found the topography was not within normal limits. So we asked her to be on hold and come after 6 months or a year. But surprisingly, she came back to us after 5 years, and over the next few follow-ups, we saw that she was going into keratoconus and developing ectasia. So what if my LASIK patients show this change if I operate them and they don't do it before? There are various risk scoring systems available in the literature, and we do use them each day, and also the PTA and the residual stromal bed thickness. But are they sensitive enough, or how do we assess abnormal topographies beyond this ectasia risk scoring systems? These are the topography maps of the same patient. If you see from 3 different machines, Pentacam, Opscan and Galilei, they all look the same, but which is the best for detection, and they all have the keratoconus screening indices, but are they reliable, sensitive and specific enough? We need to know that. They are all Schleimpfeck based devices, which gives the best of image quality and also the best of scans, and with minimal distortion. And also they have the multiple keratoconus screening indices, but the sensitivity and specificity of each of them for the Indian population is not known. So, is there a perfect topographer to screen these refractive patients, and which keratoconus index is most reliable and which one do you use? And also, can we differentiate the subclinical keratoconus? So, the purpose of our study was to determine and compare the predictive ability of 3 different Schleimpfeck based devices in differentiating keratoconus and subclinical keratoconus from normal cornea. It was a retrospective cross-sectional study with 70 normal eyes, 84 subclinical keratoconus eyes, and 92 keratoconus eyes. They all were subjected to all the 3 scans, Pentacam, Galilei, and Cirrus, 3 readings each, and a statistical analysis was done for sensitivity, specificity, area under curve, and positive and negative likelihood ratio and predictive value. What we found for the sensitivity between the keratoconus and the normal eyes was, for the Galilei, the surface asymmetric index showed the highest sensitivity. In Pentacam, the relation thickness, the Ambrosio relation thickness average and the average pachymetry progression index showed the best sensitivity. And in Cirrus, the 4.5 millimeter zone of root mean square values per unit area back showed the maximum sensitivity. There is enough literature on Pentacam and Galilei for the best sensitivity and specificity, but for Cirrus there is no literature present. Also, the specificity for Galilei was best for percentage probability of keratoconus and surface regularity index. On Pentacam it was the index of height asymmetry, and on Cirrus it was the symmetric index back, Beloshi-Kaloshi-Versace index, and the 8 millimeter zone of RMSB. How do we distinguish between, and which is the best parameter to distinguish the subclinical and the normal eyes? It was the standard deviation of corneal power in the Galilei, bad D of course in Pentacam, and the symmetric index front in Cirrus. And the best specificity was found in Galilei with surface regularity index, index of IHA and minimum height in Pentacam, and RMS SB of 8.5 millimeter zone in Cirrus. Comparing parameters for the best area under curve, bad D was statistically similar to that of SRI on Galilei and RMSA or back on Cirrus. Comparing for normal and subclinical, the best parameters, bad D was similar to that of SDP on Galilei, but bad D was better than RMSA back on Cirrus. So predictive ability in distinguishing subclinical keratoconus is not strong enough, and we need to have better tools. Bad D was of course the strongest indicator, as it's a multivariate analysis and the regression analysis has been taken care of, that's why. So that's why it was the best parameter. To conclude, keratoconus indices measured by all 3 machines can effectively differentiate keratoconus from normal. However, a combination of data is required to distinguish subclinical keratoconus from the normal eyes. And this is the first study to give the most sensitive and specific indices for each of the 3 devices for the same patient. Almost all the indices have sufficient strength when differentiating keratoconus from the normal cornea, but not while distinguishing subclinical keratoconus from normal. So we need to have a combination of indices. However, different grade of keratoconus are not compared among the 3 topographers, and only the screening indices are studied. Thank you.
Thank you. Any question?
Thank you.
The next paper is free paper 1625, that is making regional language translator apps from eye care professionals, Tamil, Bangla, Telugu and Malayalam. And the chief presenting author is Dr. John Davis Akara.
Sir.
Very interesting topic indeed.
I'm Dr. John Davis Akara, and my AOS number is A19733, ratified member. So, making regional language translator apps for eye care professionals. I have no financial interest. I have made these apps myself, and I have put them for free on the Play Store. You can download them for free on the Play Store. So I found that there was a need for this, that we talk about ophthalmology, but there is something which helps us in doing ophthalmology. So India is a very diverse multilingual country. There are 23 official languages and there are 122 major languages. So these are just the major languages. There are more. So you cannot expect an Indian to know all the languages. You cannot expect an Indian to stay in one place, in one region where he knows the language. Indians will travel all over India. Indians have to travel all over India. That is what we want to do. So doctors, we have to speak and interact with patients, not like engineers. We have to know the language, we have to speak the language. We often study and work in different parts of the country where the language is not our language. And many young doctors, they struggle with the language during their training. So because of the language struggle, you devote less time to the learning medicine, diagnosis and treatment. You are more worried about your language skills. So I am thinking of doing something to help students, doctors, students, help them with their language problem. So often they miss clues from diagnosis. Patients' diagnosis, their case history, everything is just yes, no. You don't ask proper questions, you don't get proper answers. Patients may tell you, but you won't understand what they are saying. There are often there are other resources available, dictionaries and books like this. So when I did my PG, when I did my UG in Pondicherry, Jipmer, I got a book like this. 30 days passed, 1 year passed, 5 years passed. I never completed that book. Then I did my PG there. I never completed this book. So most of what I learned was just by learning the others speak, my colleagues and the nurses in the hospital, all that. I never completed this book. That is the point. And there was a Tamil for Medicos book which was more useful. So in I think several years back, one of our professors released this book. They haven't modified that book and it was very useful. So that is most effective. If you have your own notes, that is most effective. You cannot use a standardized language learning book. You need a specific medical book. And I decided to make smartphone apps to help with history, examination and counseling. I translate into different regional languages. So I started with Tamil. So these are the things which subsections which I did: history taking, slit lamp examination, treatment counseling, during anesthetic block. Very important. During surgery, keep looking at the light and all that, don't move your head, what is happening, all those things. Post-op instructions. So these are things which we don't think about. We just think, okay, just have to inject and patient will tell it is paining, patient will tell it is something else. We have to understand what they say. So I made this, started with Tamil, made Bangla also, working on Malayalam and Hindi, available on the Play Store. This is how I did the coding. So this is basic HTML and converted the HTML using something called PhoneGap into an app. And this is Adobe PhoneGap build. You can upload HTML files. If you know a little bit of web designing, you can do this. So I did that and made these apps. And I received feedback on corrections, changing the design, rearranging. So initially I thought you'll just have phrases. I thought I'll have searchable options, but I found that people do not want searchable options in all cases. They just want, okay, I am at the slit lamp, these are the things which I have to ask. Even if they have been told that previously, you will keep forgetting when you are a newcomer. So all those were grouped into pages. Answers. People will ask questions, patient will say something. So you have to understand what the patient is saying. So that was also incorporated. And it was updated like that. So there was general history. There was just ocular history taking. Then there was, in the OPD setting, you can ask more history. You can do slit lamp examination, look up, look right, look left. Simple things, but you need to know it at that point. Just 2 words, you can tell them and you can continue, whatever language the patient knows. And then I had the greetings, the relationships, numbers. So all these are in separate pages. So you can ask like that. And these were the suggestions I got for giving anesthetic block was one big suggestion, because when newcomers come, they go to the block room. And then we found that it was useful for doctors new to the target language, but once they are settled in 1 year, they're fine. They don't need the app anymore. Pronunciation was little difficult even with the transliterated ones, because when you write in English, it doesn't actually match the regional languages. Preferably, you have to be transliterated to some other regional language. And we found that it was more convenient to arrange into pages rather than a search box. Even though a search box was useful, translated pages were more useful. Then we found that it is not a problem which is just a simple problem. It makes diagnosis difficult, makes treatment difficult, makes adherence to therapy difficult. It makes the patient's trust in the doctor less. So this will help in all that. It's not like other professions where you can just do something and finish it off. You have to actually build a rapport with the patient. So that is the point of this. And this is, but to conclude, I tell that language difficulty is a major problem, even though we don't look at it that way. And this is to help you in doing ophthalmology without an extra headache of learning a language. Thank you. These are my references.
Indeed, great job done.
Thank you, sir.
Only thing is whether this is available free of cost on.
Absolutely, sir. It's available free of
cost. No
cost.
financial interest.
No financial interest. No financial interest. No advertisements. It's free without ads. No, no. In fact, I got the data from my colleagues. Got the data from the nurses who helped me in OPD. So I have to give back. This data is not from myself. I just put it together. It's called PhoneGap. It's a free software. If you go to build.phonegap.com, you can do it online. You'll have to make these pages, of course. Once you make the pages, link the pages together, you can just upload the whole thing into build.phonegap.com for free, get the APK file, which you can put on Amazon App Store for free. If you want to put in Google Play Store, you have to pay $25 just one time for life. So I have done that. I am a programmer. Since school days, I have done some programming. So I have an account. If you don't have an account, you can share the APK file, or you can give this APK file in several other free app stores, including the Amazon App Store.
Any question from the judges?
In your history?
So if you ask, mainly the first thing everybody wants to know is yes or no. But other than that, you can ask what type of, when did the blurring of vision occur? Since how long you are having, then you have the number of days, months. So all those questions you can ask how many days, and then the numbers are also there nearby. So you can just correlate what the patient says and repeat to the patient so that you can make sure that the patient says and what you say is correct. Yes, because many times, even if you read what you have written, your pronunciation is very wrong. So once you get used to it, it works out. But I am working on making the regional transliteration also.
Thank you.
Do you have any feedback about from the user side?
I have given mostly to PGs working in various institutions. So these suggestions were from them. Yeah, they gave some suggestions to make it more user-friendly. Initially, I had a search box, but that was not very friendly. So they told you make it in pages, slit lamp. Block room thing was something which I had never thought of. Because block room, we never think that we need to have a translator for the block room. But that was also very useful.
Maybe you need something that can talk back to you.
Yes, that can be done. Microphone may be difficult, but I can actually have a voice playback. I can press a button, make it play a voice. That can be done very easily.
Thank you.
Yes.
We'll move ahead to the next free paper.
Thank you.
It was interesting paper. Free paper 1785 is the next paper, that is evaluation of ophthalmologist as gatekeeper in diabetic eye screening under 7 years. Presenting author is Dr. Satish Chadha.
Hello?
This one?
Yeah.
Hurting.
कहाँ से होता है फुल स्टेज?
ये यहाँ से होता है, ये
हाँ?
ये यहाँ से
ओके, पीछे पूरा खोलो। यहाँ कहाँ से जाएगा? यहाँ से?
ये भी है, ये भी
Okay. Good afternoon, everyone. My name is Satish Chadda, and my number is C14378. And I'm going to present evaluation of role of ophthalmologist as a gatekeeper in diabetic eye screening program for over 7 years. Our diabetic screening program is a well-established program for a current population of around 723,000, and this is a part of national diabetic eye screening in UK. Around 42,000 diabetic patients are enrolled in annual routine digital screening, which is around 5.83% of the population. Informed, opt-out, and medically unfit are excluded, and those that are suspended from screening are the patients in slit lamp biomicroscopic examination in the community, digital surveillance in the community, and hospital eye service. There are 2 general hospitals that are attached. This is the screening process. The invitation is given, and then the screening is done at various places. Grading is done at the central point, and the outcome is either annual screening or it is referred to the ROG, which is very important, referral outcome grader. The referral outcome grader then can send back for annual screening, or it can send back to community slit lamp biomicroscopy or digital surveillance, or it can send to hospital eye service. We have a common grading pathway where there are 4 levels of grading: the primary, secondary, arbitration, and ROG grading. Primary grading, disease negative, will go to annual screening. All the positive will go to secondary screening, and also 10% of negative, that means R0, M0, they go for the secondary screening. If there is any difference between primary and secondary, that goes to the 3rd stage of arbitration. And all referable patients, they will go to ROG, or referral outcome grading. The referral outcome grading has a choice of either annual screening or slit lamp biomicroscopy in the community, or digital surveillance in the community, or referring to the hospital eye service for the treatment or further investigation. This is a retrospective study, and referral outcome grading done by the ophthalmologist and senior graders are compared for 2 periods over 7 years. The outcome measures of annual digital screening, routine referrals, and urgent referrals to the hospital eye service, and unclassified images referred to slit lamp biomicroscopic clinics are compared. The role of ophthalmologist is evaluated in the screening program. The evaluation was done over 2 periods. First period 1 was between 2012 and 2016, 4 years, and period 2 was between 16 and 18. All the graders, including senior graders, get quarterly supervision by the clinical lead, who is an ophthalmologist. 10% of ROG grading done by the senior graders is also reviewed by the ophthalmologist in order to maintain a high standard of internal quality assurance of the grading. This is the outcome period in period 1, and here the ophthalmologist, there were 3 ophthalmologists and 3 senior graders which were involved. In grading outcome period 2, 1 ophthalmologist and 3 senior graders, they were involved. Of the grade 1, grading period 1, around 66.5% were done by the ophthalmologist, and around 32.5% of the ROG grading was done by the senior graders. In grading period 2, around 70% was done by the ophthalmologist, and 29.4% was done by the senior graders. This is direct comparison between these 2 periods. If you see in period 2, total ROG grading was 7,216, where the ophthalmologist did 70%, senior graders did 29.4%. Of all the grading done by ophthalmologist, 100% was done by one ophthalmologist, as compared to period 1, where 97.2% was done by one ophthalmologist. Looking at the referral to the hospitalized service for further investigation and treatment, the ophthalmologist referral outcome grading was 14% compared to senior graders 29.4%. This is a broad comparison, and here if you see the routine referrals to the hospitalized service in period 2 was 11.76% compared to senior graders ROG's 26.4%, almost similar in period 1, which was 16.19% by the ophthalmologist, and senior grader ROG was 20.5%. Similarly, urgent referral was compared and unclassified. There was not much difference between stable R3 in both groups. Coming to the discussion, ROG grading done by the ophthalmologist compared with ROG grading done by senior grader resulted around 70% referral back to the annual screening compared to around 55% by the senior grader. Around 50% less referral to the hospital eye service, both routine and urgent, for further investigation and treatment, and similar results were seen in both periods. In conclusion, the role of ROG is crucial in any community diabetic screening program to ensure that the patient is in the right pathway. Ophthalmologists can be entrusted the crucial role of ROG so that the quality of grading is maintained and unnecessary referral to the hospitalized service is avoided. Involvement of ophthalmologists resulted around 50% less reduction of the referral to the hospitalized service over 7-year period of our study. Additional role of ophthalmologist can include supervision of all the grading process, training senior graders to the level of ROG, and maintaining internal quality assurance. Thank you very much.
Thank you, sir, for nice presentation. I presume this work was done outside India.
Yeah, this was in UK.
So this doesn't qualify for the award, but thank you very much for sharing your thoughts with us. Thank you.
Thank you.
Just wanted to know, what do you mean by arbitration? The primary, secondary, was that a discussion amongst them?
No, if let us say that one primary grader says it is R1 M0, the secondary found some one microaneurysm and it say, or it didn't find, it says R0. So there is a difference of opinion between primary and secondary. Now, if you give this information to the patient, you can tell that patient is diabetic where actually he is not. So you may not be giving right information. So there is another level of arbitration. So arbitrator is a senior person, and this senior person will give the decision that no, there is a microaneurysm or there is no microaneurysm.
Senior to that ophthalmologist?
Say it again?
Senior to that ophthalmologist also, the one who was grading?
No, the ophthalmologist is a ROG, referral outcome grader. But these graders, one grader having 5-year experience, another 10 years, another 15 years. So the senior grader will be considered that is the final decision.
Thank you, sir.
Thank you.
We started a little late because of the conclusion of the earlier session, but we'll try to finish it in time. We are left with 3 papers and we are hardly have any time left with us. So I'll request my judges to have just 1 or 2 questions.
This one,
Single sweep retinoscopy pediatric eye screening made easy. The chief presenting author is Lakshmi KS. The free papers is 1447. May I request the next presenter also, Dr. Arun Sethi, to be prepared for presentation.
मैडम आपका है एक मिनट हाँ नहीं अभी मैंने वो इधर ट्रांसफर कर दिया ये सबसे ऊपर आया है मैं देता हूँ अभी और ब्लैंक किया हुआ
Timer, please.
Good afternoon, everybody. I am Dr. Lakshmi with I am a ratified AIOS member with my number 16911. So my topic is single sweep retinoscopy, pediatric eye screening made easy. So I would like to introduce this topic by saying that India has a lot of children, that is 39%, which is 47.19 crore, and amongst them only 40% are school going, which still includes 18.87 crore children. So in this, the schools that are there are 15 lakh schools, of which 70%, which is 10 lakh, are government schools. So what happens, whether it's a government school or a private school, is they're more concentrating on the studies and medals, that nobody is actually really interested, whether it's the school teacher or whether it's the doctor who's supposed to go to the school, is not really interested in how they are seeing. Now we come to the prevalence of refractive errors in these children. 14% of the school-going children, which is 2.5 crore children, they actually need glasses, and 70% of them they need myopic glasses, myopic correction. We are concentrating on this myopic correction, 1.75 crores in our study. What happens is, especially in a government setup, one doctor goes to one school to do entire screening, that is entire medical screening along with the hospital screening, the eye screening. So it is generally limited to the doctor asking the child whether they can see clearly. If the child says he can see clearly, then he is in one group. He won't go to the group where vision testing is done. In India, this is what is happening. So we aim to study the effectiveness of just a single sweep retinoscopy, that is, we just do one sweep of the retinoscopy as a refractive screening modality in school-growing children. This is a prospective study. We did this for 5 months. We excluded all the media opacities, previous intraocular surgeries and nystagmus. What we did was we made the children stand in a straight line in their own schools, and we started doing single sweep retinoscopy, sweep in either direction, 180 degree and 90 degree in both the eyes. Major thing that we did was, we did this in their own schools and we tried to darken the environment, as you can see in this video, that we have tried to darken it. And we also compared doing this single sweep timing to that of autorefractometer timings. So after we did this, in each case, this was to evaluate the effectiveness of whether single sweep retinoscopy works or not. So we did vision screening, autorefractometry and subjective correction in all the kids to assess the accuracy of these tests. And after doing this, we realized that in the with reflex and against reflex, the myopic group included 92.36%, which shows that there is a very high true positive rate. Along with that, there is very high sensitivity to this test. After statistical analysis, there is a very high positive predictive value and accuracy. But along with that, we have to see that specificity is very low, so we cannot actually use this as a diagnostic test. The value of high sensitivity, negative predictive value and accuracy suggests that this is an excellent screening tool in schools. And when we compare the time taken, as we can see in these videos, the first video gets over and stops, second video continues to go, and it is statistically significant, proven. The advantages of this technique is it can be done by optometrists, ophthalmic technicians and not ophthalmologists. In India, we have one ophthalmologist for 250,000 patients in a rural setting and 25,000 patients in an urban setting. Only an ophthalmologist cannot be held responsible for all the screening, so it can be done by a lot of people. It is inexpensive and it is easy and fast. We have a few limitations as well. There is a lot of inter and intra-observer variation that we found. Due to room changes, we cannot darken a few rooms. Along with that, children's cooperation, they will not look farther. They will keep looking at the retinoscope. But that doesn't affect our study very much because it only increases the sensitivity and quantification is not possible. Generally, current scenario, whatever we are supposed to do, this takes about 8 minutes time. But it is too much. 8 minutes for each child, which is 2.5 crore children, it is too much. So various efforts by eminent people have been done to shorten this time or to shorten the burden, to decrease the burden. The one study is by Priya Adishesha Reddy et al., who said that class teachers should screen the children. This actually saves some time. But the problem with this is the class teachers have their own burden. They don't think that this is their responsibility. They don't really do this. Second, Lapam Panda et al., they actually said photo screeners to school-going children is very accurate. But each photo screener costs 5 lakh rupees. We cannot give this to each doctor who is going to visit. Abadan Khan Amitava et al., they actually said that Bruxner's reflex testing for anisometropia and amblyopia detection. This is actually a very quick test, very good screening for anisometropia, but doesn't quantify the, but doesn't diagnose all the myopes. So I would like to conclude that in comparison with a lot of other studies, our study is economic, easy, and it is a quick method. Single sweep retinoscopy is a quick method to identify those who need further evaluation, and only those children can be taken for evaluation. Thank you.
It's a quick method, but there is a tendency of missing out the good proportion of children because it's a pediatric age group.
Sir, if they are looking at the retinoscope also, it will be against reflex only because they are accommodating more, it goes against reflex. So we are not missing any myopes. We might be missing myopes less than 1.5 diopter who will not develop amblyopia even if there is anisometropia, which will not hamper their mental and physical development later on. Only the high myopes we need to screen who actually need glasses can be identified.
One research opens the window for another research. This is good one. Thank you.
Thank you, sir.
The next one is They See, They Learn, School Screening Project. Chief presenting author is Dr. Arun Sethi.
So good afternoon. I'll be talking about a very novel project that we have. It's called They See, They Learn. It's a method of high volume screening mainly for refractive errors. About, as our previous speaker said, about 407 million children under 16, that's 40% have some refractive error. And so many are expected to be blind if we don't correct these refractive errors. And it accounts for 1/5 of the blind children in the world. So screening, school screening is the second largest program of the NPCV and estimates about 0.8 out of 1,000 children using the correlation between under 5 mortality rate and prevalence. So what are the barriers? So lack of awareness, affordability and non-availability of services amongst children in these schools. School screening is not compulsory in all schools. The standard of screening is not uniform at the moment. 49% of eyeglass wearing children failed a visual assistant. This is the observations we've made. 28% of the non-glass eyeglass wearing children have failed the test. So the Arunodaya project came up. So what are the objectives? To identify children with possible visual inability to see greatly inspects a student ability to learn. That is more than 80% of what a child learns in school is from the visual pathway. And to prevent amblyopia, to catch various other morbidities, ocular morbidity early. So why schools? The larger number of children readily available for screening can be accomplished in a short period of time because they all accumulated in one place, far less expensive than a comparable service in another sector of healthcare. Ongoing opportunities to observe, assess and keep examination records, which is very important. Documentation is very important. An opportunity to serve children who we've already identified at regular intervals. We can by revisiting these schools. So value of screening process depends on how well the program is undertaken and how clinical findings are analyzed. Results must be communicated and followed on with referrals and regular visits at these centers. So evaluation of screening program, to determine the effectiveness of vision, we do these screening programs. Careful evaluation of planning, implementation, referral, outcome must be completed with each vision screening. So we screened, in the phase 1 of this project, we screened about 20,000 kids, and we generated about 2,400 referrals, and total staff was also screened of 556. So what was the methodology? We had divided the methodology in 2 parts. One was at the campsite, the other one was once we visited camp before. The school authorities and everybody knew of our coming much before. A verbal consent was taken from the parents and the teachers and the principal. And the teachers were taken into confidence. A health lecture was delivered at these rural government schools that we screened, and the teachers were taught the e-chart and were taught how to identify basic refractive errors and vision problems. Then once we set up the camp there, we had registration for documentation. We had a vision test by the e-chart. Or by the e-chart, and we by determination of the refractive error, we used photo screeners, auto refractors, and where required we even did retinoscopy. There was an ophthalmologist amongst the team who was examining the children with a handheld slit lamp, as well as a torch examination was done, and glasses were dispensed at the end, and we always gave 2 pairs of glasses to each child. The reason being is the loss of one glass can lead to the reoccurrence of the refractive error and the problems. So there are photos from the campsite. So we targeted mainly rural government schools which lacked the affordability and lacked the accessibility for eye checkups. This is how we gave forms and did the registration. This is the camp setup where we had a refractionist and an optometrist work up the patients. Vision assessment was done by the e-chart. Auto refractometer and photo screeners were used. Doctor consultation was at the end, and we had the teacher's support and the children's support as well. And we gave free spectacle distribution, 2 pairs for each child, and in the end we had some happy children. So key points, we noticed that refractive error rate was 11.4%. Large majority were first-time glass wearers. Girls had more refractive errors than boys and were more compliant as well. And higher among, the refractive error was higher among older children, and 410 plus were referred and followed up at the base hospital. So these are figures from each campsite. We had 39 schools, and it showed the refractive error at each school. The age distribution, we noticed that between the 10 to 18 years had the maximum refractive errors, and above 13 had the maximum in number. And again, so glass dispensed gender-wise, the girls had more refractive errors, which was noticed. Myopia and astigmatism was the more common eye disorders that we noticed, and amongst the types of astigmatism, and we had reference from each school. Thank you.
Thank you. I know your number, AIOC number.
My AIOC number is just 1 second. It's A17392. A17392.
The next presenting author is Dr. Swami. Thank you very much. Characteristic of severe ROP babies in the eastern India. Are we screening enough?
ROP. A very good afternoon. I am Dr. Somen Mandal. My AIOC number is M14796. Shall I start?
Please.
Retinopathy of prematurity blindness in India is increasing due to highest number of preterm births in the world.
suboptimal neonatal care, lack of awareness, screening and treatment programs not in place, and we have, for the last few years, we have seen an increasing number of NICUs and SNCUs opening all over the country. Now, severe ROP is a potentially vision-threatening disease, as we all know, which, if left undetected and hence untreated, might lead to devastating visual outcome. But timely and effective screening can save the babies from irreversible blindness. Well, we all know the criteria for whom to screen and when to screen. The aim of our study, in spite of all the well-laid criteria, was to define the characteristics of babies who had severe ROP, with special emphasis on the babies who have gone irreversibly blind, that is stage 5 ROP, and to explore the factors responsible for lacuna, if there is, in proper and timely screening of the babies in need. As you can see, it is retrospective by nature, where the medical records of the babies seen for ROP screening in 2 tertiary care centers of West Bengal were analyzed, and the time frame being 3 years. Inclusion criteria were babies who had type 1 ROP, as well as babies who had stage 4 and stage 5 ROP. Type 1 ROP were named Group A, all stage 4 ROPs were Group B, and stage 5 ROP with total retinal detachment were Group C. Now, these are some of the representative pictures of Group A, Group B, and Group C. The total number of babies seen in this study period were more than 1,000 babies, where 52 babies fulfilled the inclusion criteria. Number of babies in Group A were 21, almost 40, more than 40% actually, which was closely followed by Group C babies. Now, this is the geographical distribution of the residence of babies from Center 1 as well as Center 2. The mean birth weight was 1365 grams, and the mean gestational age of birth were 31 weeks. Now, in these babies, 20 babies had been discharged from medical colleges, and 19 were from government-run SNCUs. The median age of presentation were 5.5 months. In subgroup analysis, Group A, the median age was 2.1, Group B 4.3, and Group C 6.5. So the difference of outcome in stages of ROP between the groups were statistically significant. Mean birth weight was 1365 grams, and again, the difference in outcome between Group A and Group C was statistically significant, whereas Group B and Group C were not. In Group C, that is the worst prognosis babies, none of the babies had been seen in the first month of life. And 16 of these, almost 80% of these babies had no advice from neonatologists for retina examinations at the time of discharge from NICU. Surprisingly, 8 of these babies had been discharged from government SNCUs and 6 from medical college and ICUs. The 4 babies which had actually been advised for retina examination but which never came up were from medical college SNCUs. The parents said that they did not turn up because the distance from the home to the eye hospital was far. As you can see, it's more than 100 kilometers in 3 babies. So all the 20 babies came with a white pupillary reflex once the pediatrician or the parents saw. So we all know the National Neonatology Forum as well as several studies from India have already laid out very well described guidelines, 2,000 grams or less, 34 weeks or less, all babies to be screened, and first screening has to be done within day 30 of life. Now, the present study highlights the point that the babies who had worse prognosis were not screened at the recommended time. But the babies who had been seen late, Group C, had first been seen at 6.5 months. The difference in the median time of presentation with reference to the stage of ROP was found to be statistically significant. Anatomical outcome of ROP had a stronger causal relationship with time of screening of ROP when compared to the birth weight, which means that given the same birth weight, timing of screening of ROP determines whether the baby is going to be blind or not. So the babies in Group C did not have a single ROP screening examination. Out of the 20 babies, 80%, 16 of them had been advised, and 4 had been recommended that the parents could not bring them to the hospital. So if more ophthalmologists were trained to screen ROP, it would have been easier for the parents to bring one, to find one ophthalmologist nearer to home, and so the needless blindness could have been prevented. Neonatologists and pediatricians should be more vigilant regarding the ROP screening. Another similar study, the PGI Chandigarh group had come up with this. They had opinionated that likely reasons for non-screening included lack of awareness amongst pediatricians and ophthalmologists, non-availability of trained ophthalmologists, and a poor knowledge of the screening criteria. Well, the limitations of the study were that it was a small sample size and it is a hospital-based study which might represent just the tip of the iceberg. So to conclude, Eastern India is right now urgently in need of a comprehensive screening program in ROP with a task force comprising of neonatologists and ophthalmologists. Timely referral of the baby to an ophthalmologist of utmost importance. We need more trained ophthalmologists, and tele-ROP projects might be a possible solution. Thank you.
Thank you. Any question? Thank you.
Thank you.
एक मिनट में वहाँ ब्लैंक कर लेता हूँ पहले स्क्रीन को ब्लैंक कर लेता हूँ
अच्छा अच्छा
Actually, I think जगह बनाते हैं next batch.
Thank you for everyone for attending this session.